Assalamualaikum everybody. My name is Dr. Summaiya Saeed and I'm assistant professor in the Department of Surgery. And as we have been taken a previous class by Dr. Zain about parathyroid glands and its diseases that are medically treated, my task here is to confer to you the parathyroid gland when it is surgically important to remove it. So we will discuss in this lecture that when is the surgery indicated and how we approach towards the gland, what are the preoperative things that we need to know, and then how the surgical removal of the gland is made. And after that, what are the complications, right? Indications and surgery and then the complications. Before we start, let me show you a video so that you can understand this topic better, and then we will continue with the lecture. Can you hear me properly and can you see everyone? Can you see everybody? Can you hear me? Let me show you a video and then we will continue with the lecture.
When Jason Townsley began
Can you hear the voice?
experiencing unusual symptoms a few years ago, he didn't realize they were classic signs of hyperparathyroidism.
Brain fogginess, aches and pains in my muscles and bones, irritability, things like that. Without any rhyme or reason. For a few days I'll be very irritable, and for a few days I'll be very fatigued.
When his doctors couldn't pinpoint the source of his problem, Jason, who lives more than 1,000 miles away, decided to seek treatment with Dr. Michael Ye, chief of endocrine surgery at UCLA.
He had a scan done in Billings, Montana, and that was negative. A lot of the scans that are done on the outside are really not that sensitive.
I started researching my options on the internet, and I found several different people to do the minimal and invasive procedure. But what I liked about Dr. Ye and UCLA was they weren't trying to sell a service. They were just putting their information online and letting make your own decision on whether or not you wanted to pursue that or not.
Using the latest state-of-the-art imaging equipment available at UCLA, Dr. Ye was able to locate an abnormal parathyroid gland.
The parathyroid glands are 4 calcium-regulating glands in the neck. They're quite small. Each one is about the size of a grain of rice. They were actually the last glands or last organs of any kind discovered in animals. What they do is they regulate the body's calcium. That's their main purpose.
For reasons that are not yet known, one or more of the parathyroid glands can go into overdrive, producing massive amounts of the parathyroid hormone, also called PTH. The result is primary hyperparathyroidism. Diagnosing it usually requires a simple blood test.
Large amounts of parathyroid hormone going to the bone, calcium continuously coming out of the bone, causing the blood calcium to rise. Ultimately, that excess calcium is going to get filtered by the kidney. It can cause kidney damage and kidney stones.
The disease is most common in postmenopausal women who have a high risk for osteoporosis and particularly hip fractures.
Up to 1% of women over 50 are affected by primary hyperparathyroidism. That it doesn't sound like a lot, but if you talk about 1%, that is one of the most common diseases we face in medicine.
The good news is, in most patients, a minimally invasive 20-minute surgery is all it takes to get cured.
90% of patients with primary hyperparathyroidism have a stable parathyroid adenoma or benign tumor that is causing the problem, and the remaining glands are normal. Having said that, there is that 10%, and oftentimes they can be picked up on scan, and there are some times where even if the scan doesn't show a second abnormal gland, they can have it at the time of surgery, which has led us to this belt and suspenders approach to the operation, where we simultaneously check all 4 glands and measure the parathyroid hormone level in real time. And with both of those, we have increased security.
In 2011, Dr. Ye and his team decided, instead of looking at just the suspected gland, They would inspect all 4 parathyroid glands in every surgery patient as a matter of course. Through a 1-inch incision and using a muscle-sparing approach, the thyroid is moved aside and the abnormal parathyroid gland is removed. The remaining 3 glands are inspected.
We've removed the offending gland. We've seen 3 other normal glands.
That leaves little to no chance that a rogue gland would stay undetected in the body and dramatically decreases the risk of repeat operations.
When we were operating, we had 3 blood levels for parathyroid hormone. Now, the operation itself, there was no blood loss. We've drawn 3 levels by now. So let's go take a look at what's going on in the lab while the patient's waking up.
PA analyzes the patient's PTH levels before, during, and right after surgery. The effects of the operation are immediate.
It's fallen by half in 5 minutes, a little more than half, and it'll likely fall again.
The out-of-control hormones that wreaked havoc on the body are back to normal levels before the patient even leaves the operating room.
In a patient with an abnormally high level of PTH, that hormone just streaming out of the abnormal gland continuously. Once we close off the blood supply, it's got nowhere to go. So then every 5 minutes, that level should drop by half. So we're looking for that decay, and usually by the time the patient's eyes open, we know it's normal. What we find is we can cure about 99% of people durably with this approach. I wish that number were 100%, but there are just that 1% of people that are very challenging cases.
My son looks little, and she said must have taken advantage of seeing smaller.
Patients like Billy Kempler are usually surprised to see that the surgery hasn't left much of a trace and hardly any pain. What's more, patients leave that same day with minimal recovery time.
I was told I can resume normal activities right away, exercise within a day or 2, and heavy lifting, 2 to 3 days after that.
2/3 of patients have a significant improvement in the quality of life after parathyroid surgery. Within 2 years of parathyroid surgery, a woman with osteoporosis will gain bone and hold on to that bone for 10 years or more. It's really a dramatic improvement. In order to be a professional at anything, it involves repetition, doing things a lot. We've done that for years here, and I'm really proud of the level of quality that we offer. I'm completely convinced that we offer the highest level of care available in the world. It is good to come and get a high level of quality, but it is even better to come here and be treated like you're really somebody special and to be embraced as a member of the family. And this is
by this video. Let me go through the development of the parathyroid gland quickly, and then we will come back to the surgery. This video was just that you guys should know what we are talking about, right? So as we all know, that anatomy of parathyroid glands, these are situated behind the thyroid gland, 4 in number. Upper 2 glands are constant in position. They arise from the fourth branchial arch, and the lower 2 glands are variable in position. They are in front of the recurrent laryngeal nerve. Each gland weighs about 40 to 15 grams, brownish in color. They are firm. I'm going to stress very quickly because you have gone through this lecture with Dr. Zain. It is brownish and firm gland, which sinks in the fluid like fat, but the fat floats. Blood supply is superior and inferior glands receive from the inferior thyroid artery and its anastomotic arch. As I told you before, the superior gland arises from the fourth pharyngeal arch and it goes in higher in position, and the inferior travels downward and it is from the endoderm of the third pharyngeal pouch, and hence it is called parathyroid 3. As the video also said, that it regulates calcium metabolism. The gland secrete parathyroid hormone that controls the calcium metabolism, which converts vitamin D to its active form, 125 dehydrocholecalciferol in the kidney. This is the active principle of this hormone. PTH increases the absorption of calcium from the gut. It also mobilizes the calcium from the bone, causing osteoclastic activity. and increases the calcium reabsorption from the renal tubules. Calcium, total plasma calcium consists of ionized and unionized form. That is, it is bound and unbound to the albumin. And total calcium, if we get a serum calcium level, it is 8.5 to 10.2 milligram per deciliter, which is 55% bound to the albumin and 45% in ionized free part. That is 4 to 5 milligram per deciliter. Common protein, as I told, that it is albumin, which beta globulin chains bound to the calcium. Level of calcium is controlled by parathyroid hormone, calcitonin, and vitamin D. Calcium is important in blood coagulation, neuromuscular activity, and cellular activity. For example, when you do a thyroid surgery and you mistakenly remove a parathyroid gland, then after some time you see that the patient is going into technique. What is technique? It is spasm because of decreased calcium levels. The muscle go into spasm. Then we have to give that patient calcium. Hyperparathyroidism is of three types. Primary, which is the primary disease of the parathyroid glands. Secondary, it is due to chronic renal failure or due to malabsorption of vitamin D deficiency, like rickets, due to chronic hypocalcemia. There is secondary parathyroid hyperplasia, and tertiary. Tertiary is like there is a third cause. Neither it is in the gland, neither it is from the kidneys. It is a third cause, like autonomous reactive hyperplasia of parathyroid glands due to renal transplantation. It is the third most common endocrine disease after diabetes and thyroid. The causes are three types. Number one, adenoma. Adenoma is 75% to 90% cause of primary hyperthyroidism, and usually it is only the one gland that has a adenoma. Out of the four, there is only one gland that has adenoma. Hyperplasia, when it occurs in all the four glands, not in one gland. Carcinoma is rare, but it occurs only in a solitary gland. What are the clinical features of hyperparathyroidism? You can remember it by bones, stones, groans, and psychic moments. You will remember this abbreviation, and then you can easily understand what this disease is about. When a patient is coming to you having bone pains, having renal stones, and he said, my stomach is upset, and you think that he is a bit psychiatric illness as well, then you should investigate and see what it really goes to. Most likely it is the parathyroid gland that needs to be evaluated. In bones, due to raised parathyroid hormones, it causes increased osteoclastic activity. What is osteoclastic activity? It's body's absorption of new bone. In the bone, there are new bone formation. That is osteoclastic activity, leading to decalcification of the bone, resulting into bone pain, subperiosteal erosions, which cause a lot of bone pain. Stones due to hypercalcemia, 25% of the patients develop stones, which are calcium phosphate and calcium oxalate type. Abdominal groans, like I previously mentioned, hypercalcemia stimulates gastrin, which causes peptic ulceration. And hypercalcemia can also precipitate in acute pancreatitis, causing gallstones as well. Pancreatitis is a very severe disease, inflammation of the pancreas, and it radiates, the pain radiates towards the back, and it is very, very severe pain, and it cannot, the patient has to get admitted to relieve its pain. Psychic moans, like hyperparathyroid patients, behavioral and neurotic problems, they have that, depression, anxiety, and these are also related to calcium levels. Other features like skin necrosis, corneal ulceration, band keratopathy. Band keratopathy is a band that comes, keratin accumulation in the cornea. Pseudo gout. The gout is due to increased uric acid levels, but pseudo gout due to increased hypercalcemia. There is pseudo gout, that is like pain in the metatarsal bone. Backache, polyuria, polydipsia, constipation, glycosuria, and hypertension. All these are related to acute hyperparathyroidism. What are the crises? When there is a sudden increase in PTH levels due to rupture of the parathyroid cyst, that is called Brown's tumor, or bleeding in the parathyroid gland, or severe dehydration that causes increased calcium and increased hypercalcemia, and that precipitates the crisis. Secondaries in the bone, like if your patient has a breast tumor and it metastasis to the bone, then the secondaries can also cause increased calcium in the blood, and they may lead to acute hyperparathyroidism. Clinical features are the same, that is abdominal pain, vomiting, dehydration, oliguria, and muscular weakness. When you get a blood test, then serum calcium is always high. It is greater than 12 milligram per deciliter. What is the treatment of the crisis? If a patient comes to you, what do you have to focus? Number one, forced diuresis. You have to give the patient saline approximately 3 to 5 liters with furosemide, that is diuretic, so that you cause the kidneys to forcefully diurese all the calcium that is coming in the blood, and it should excrete out. Dehydration should be prevented. Dehydration, normal saline 300 ml per hour. You should get 300 ml per hour. And to reduce the calcium levels, multiple drugs are used like mitramycin, calcitonin, prednisolone, bisphosphonates, and cinacalcate. Mitramycin controls the hyperglycemia of malignant disease, but it is for a short acting. Steroids inhibit the effects of the vitamin D. Because they inhibit inflammatory changes and they are very good at it. The dose is 400 milligram per day, IV for 5 days. Bisphosphonates like caltonate and palmidronate, they increase metabolism, mobilization of calcium from the bones. They are for making the density of the bone better. Cinacalcate is a calcium receptor agonist which reduces the calcium serum calcium levels. It causes calcium to attach to itself, and it decreases the calcium levels in the blood. What are the investigations? High serum calcium. When you get a serum calcium test, then it is always greater than 10 milligram per deciliter. Normal is 8 to 10. It is always greater than 10. Albumin levels are also assessed because you need to know the ionized calcium and non-ionized calcium as well. Serum phosphate level is this. Increased PTH level is specific and diagnostic for hyperparathyroidism. Bone density assessment. You get a bone density of the bones done, and it is always low. Vitamin D estimation is always done, and then increased urinary calcium levels. It will always be greater than 250 milligram in 24 hours. Raised alkaline phosphate levels. All of these are related. Why? Because these parameters show you either it is a primary or a secondary hyperparathyroidism. In primary hyperparathyroidism, the parathyroid hormone is high, the calcium is high, and phosphate is decreased, as it is the primary gland disease. While in secondary hyperparathyroidism, the parathyroid hormone is high, but the calcium level is normal, and phosphate level is increased because it is coming from the kidney. When you get an X-ray, when you have made a diagnosis and you get an X-ray of the bones, then you see this erosion of the radial side of the metatarsal bone, middle phalanx. Erosion. You see this? This is, and multiple bones are hyperdense. They are calcifications in the bones, and paper lesions. Paper lesions in the skull. Paper lesion is yes. When you get an ultrasound done, detect the renal and pancreatic disease. Then ultrasound of the neck is done to detect the enlargement of the parathyroid glands. CT, MRI of the neck and mediastinum is indicated if you get an enlargement of the parathyroid gland. What are the special investigations? Number one, the selective venous sampling of PTH and the serum PTH levels you need to do, which I told you are greater than 0.5 milligram per deciliter. Technetium scan or radioisotope scan, so as we say it, shows hot spots that are diagnostic for adenoma, parathyroid adenoma. You see this? These are the hot spots. There is also a system B isotope scan in which a single positron emission computerized topography is done, and the system B is a technetium 99 labeled scan, and it is more specific for adenoma. Urinary cyclic AMP levels are also increased in 90% of the cases. Arteriography, venous sampling, and ultrasound guided biopsy are also done. Once you are done with the ultrasound and the system EV scan, then you can go for arteriography to know the arterial pattern, and venous sampling to know the PTH levels and the calcium and phosphate levels, and ultrasound guided biopsy can be taken from the gland to confirm the diagnosis. Differential diagnosis can be secondaries in the wound, like I mentioned, the secondary metastatic from the breast carcinoma. Multiple myeloma is a plasma peptide disease, which also causes these kind of symptoms: hypercalcemia, vitamin D intoxication, sarcoidosis, functionating carcinoma, that is adrenal disease, and familial hypocalciuric hypercalcemia. It is an autosomal dominant disease with mild raise in the serum calcium and PTH levels, secondary to the mutation in the cell membrane and calcium receptor. I'm going through this fast because this is not the topic we are dealing with. This now comes the topic that we are dealing with. Like, once we have gotten an idea about what the parathyroid gland and its hyperparathyroidism is, now we come to the surgical treatment. Surgical treatment is parathyroidectomy. What are the indications of parathyroidectomy? When the medical treatment fails, number one, the symptoms are severe, the patient is young, markedly reduced bone density that you have to go in, serum calcium more than 11 mg/%, urinary calculi that are causing the patient's day-to-day life hindrance, neuromuscular presentation, and urinary calcium more than 400 mg in 24 hours. What is parathyroidectomy? It is the surgical removal of the gland and implantation of the gland in the forearm muscles, brachioradialis, or the neck muscles. Even when we dissect the thyroid gland, huge thyroid gland, and the parathyroid gland is removed accidentally, so we re-implant it in the muscle mass, in the deltoid or in the brachioradialis and in the sternomastoid, basically. If it is a carcinoma of the parathyroid gland, then additional hemithyroidectomy is done and post-operative radiation is given to the patient. If it is a simple adenoma, that is one gland, then targeted approach can be taken. Means that you can map the gland by system EB scans and ultrasounds, and then one gland is removed, but the rest of the glands are not removed, and that is sufficient. And all four glands are diseased, like in hyperplasia. Transcervical thyroidectomy is also done along with total parathyroidectomy to reduce the persistent and recurrent disease. What is the non-surgical care? Good hydration, regular exercise, avoiding immobilization. Daily calcium and vitamin D intake is done in patients who have recovered from acute crisis. Estrogens are reduce the calcium levels and maintain bone density, so they are used. This estrogen receptor modulator is also used, and bisphosphonates are given to increase the bone density. And as I previously mentioned, calcium the receptor drugs are also given to reduce the levels of calcium, parathyroid hormone and calcium. When is parathyroidectomy indicated? Number one, indications in primary hyperparathyroidism, as I mentioned, when the medical treatment fails and young patient and recurrent symptoms and stuff like that. Symptomatic patient. Number three, in asymptomatic patients also, parathyroidectomy is taken place when the criteria is like raised in the serum calcium level more than 1 milligram of upper limit of the normal calcium range. In 24 hours, if the level is 400 milligram, creatinine clearance is reduced to more than 30%, then the surgery is indicated. Bone density greater than 2.5 standards deviation below the peak bone mass, when the bones are weak, when the age is below 50 years, when the medical therapy is not giving help to the Patient. What are the pre-operative preparation that needs to be done? Vocal cords need to be assessed in every thyroid or parathyroid surgery. We need to assess the vocal cords. It is a pre-operative. Uh, it is done pre-operatively by indirect laryngoscopy. Why? Because recurrent laryngeal nerve goes in its path, and during surgery it can be injured, which causes the paralysis of vocal cords. High calcium levels preoperatively may be require treatment for hydration, diuresis. If the serum calcium levels are high, they need to be brought in a respectable level, like by hydration, diuresis, steroids. Steroids like prednisolone is given 20 milligrams twice daily for 5 days before surgery. Calcium phosphate infusions are also given. 200 units of calcitonin subcutaneous injections for 5 days is also given. This is all to bring down calcium into its normal levels. Bisphosphonates are also given to increase the bone density. Achha. Then what is the position that we make in hyperparathyroidism surgery? General anesthesia is used with neck hyperextended. Neck is hyperextended backwards by placing roll sheets under the shoulder blades. Head is placed in a head ring. It is placed in a head ring. Head end of the table is raised to a semi-erect position. In this position, we can visualize the thyroid gland and the parathyroid gland better. And this is called semi-Fowler's position. If you have any questions, you can ask and you can stop me in between as well. Incision, when we come to incision, the horizontal skin crease incision that is given, or collar incision that is given for the thyroid is done for the parathyroid gland as well. It is 2 finger breadth above the sternal notch and from one sternomastoid to the other. That is called Cocker's thyroid incision. Strap muscles are separated after opening the deep fascia in the midline. Thyroid gland is mobilized, as we saw in the video. It is mobilized to the side and identify the parathyroid adenoma. When it is an open surgery, all 4 glands are inspected, and the parathyroid gland having the adenoma is mobilized, and it is close to the recurrent laryngeal nerve. So recurrent laryngeal nerve is separated and then it is removed. The end artery of the parathyroid gland is identified and ligated, right? If it is a single adenoma, it is separated from the adjacent thyroid tissue by Gauss dissection, and frozen section is sent to the lab. If it is an open surgery, frozen section is sent to the lab, and then we wait for the results. If it is an adenoma, then we remove it. But nowadays the investigations are so much so that we identify the adenoma beforehand. We don't go for frozen section biopsy on the table. Total thyroidectomy is done for parathyroid hyperplasia, in which all 4 glands are removed. 1/3 of the gland is auto-transplanted into the forearm in the brachioradialis or sternomastoid muscle, and it is marked with a stitch so that next time, if the disease reoccurs, we can remove it from them. The gland to be transplanted is sliced into 1 millimeter pieces, and around 18 pieces are embedded in the muscle. What are the complications? Hemorrhage, recurrent laryngeal nerve palsy, hungry burn syndrome, that is increase in PTH levels, and that takes up all the calcium. Severe hypocalcemia is a problem when all 4 glands are removed, as I previously mentioned. In bilateral neck exploration, migration or inability to identify the transplanted parathyroid gland is often a problem in auto-transplantation of the parathyroid gland. That is the reason why a stitch is always placed when parathyroid gland is implanted. What is hungry bone disease? It occurs usually in patients with preoperative hyperthyroidism. They have increased bone breakdown in hyperthyroid state. When a patient's thyroid hormone levels drops acutely after the surgery, It is stimulus to break down the bone. The bones are now hungry for calcium and remove calcium from the plasma rapidly. It usually occurs after parathyroidectomy, thyroidectomy for toxic thyroid, and prostate cancer. Sudden cessation of existing increased bone breakdown leads bone to absorb calcium, magnesium, and phosphorus. Hypocalcemia, hypophosphatemia, hypomagnesemia, hypercalcemia are four typical features of these patients, right? And bone-specific alkaline phosphatase continues to rise. You have to give supplementation of vitamin D and elemental calcium. Postoperatively, calcitorol with 2 milligram calcium supplement, and monitoring is done, evaluating serum calcium, albumin, magnesium, and phosphorus, and alcohol phosphorus. What are the effects of the surgery? As we see in the video that I shared before, that the patient is up and about after 2 to 3 hours after the general anesthesia was over, up and about. He's up and about. The marks are not that much, so the pain is not there. Among the neuromuscular symptoms, proximal muscle weakness responds very well, but the respiratory muscles, if they are involved, it does not help that much. Psychiatric illness, depression, they are improved by the surgery. The bone mineral density in the hip and lumbar spine becomes better. Nephrocalcinosis is improved by the surgery. What is the operative failure? As in the video, it was also mentioned, 1% of the patients we cannot save. 99% get help. What are the surgical approaches? As we discussed, the traditional approach is the classical approach, in which in general anesthesia, bilateral neck exploring the bilateral neck to remove parathyroid tissues. All 4 tissues are same, and then if adenoma is identified, frozen section is sent, and then it comes back and it shows 95% of the cure rate because you have identified and biopsied the patient there and then. Minimally invasive surgery is now in more practice these days. It is also called targeted approach. It is done in single adenoma of the parathyroid gland, and it is done under cervical poke. By system EB scan, the adenoma is first identified, marked, and then direct incision is given over that parathyroid gland under regional block, and then it is removed. Medial sternotomy is often done when parathyroid is in anterior mediastinum along with thymus. Thymus is also along anterior mediastinum. If we see the thyroid, then medial sternotomy is done. Nowadays, video-assisted parathyroidectomy is also done. Localized single adenoma using multiple ports. You have been seeing these lab polis. There are 5 millimeter ports. Even 5 millimeter ports are used on one side with intermittent CO2 infiltration and then suction and irrigation. By suction and irrigation, this video-assisted parathyroidectomy is done. Endoscopic is also done for a single adenoma. These are all approaches for a single adenoma. These are minimal invasive surgeries. To remove the tumor in the gland, low pressure insufflation is done and 5 millimeter 4 ports are placed, and then endoscopic removal of parathyroidectomy is done. What is remedial parathyroidectomy? It is done for persistent hyperparathyroidism or recurrent hyperparathyroidism. It is done through lateral approach, that is finds approach between the anterior margin of the sternum and the strap muscles. Subtotal parathyroidectomy is done in hyperplasia or secondary hyperparathyroidism, and 3.5 glands are removed and half of the gland is reimplanted. In this figure, these are the 4 glands. 1, 2, 3, 4. All 4 are removed. Then 1 gland is taken, and it is 1 millimeter slices are made. Approximately 18 slices are made, and then they are replanted in the sternomastoid muscle, and they are marked with a clip or a stitch. What is Men's syndrome? Men's syndrome is an inherited disease. It is an autosomal dominant disease. There are two types. Type 1 is called Werner syndrome, which is a defect in chromosome number 11. It includes parathyroid hyperplasia or adenomas, pituitary tumor, and pancreatic tumor, like endocrine, like insulinoma, gracinoma, glucagonoma, VIPs. Parathyroid is also included in sickle disease, that is MEN type 2A. It is defect in chromosome number 10 and it includes medullary carcinoma of the thyroid, pheochromocytoma, that is adrenal gland tumor, and parathyroid hyperplasia. Type 2B includes medullary carcinoma of the thyroid, pheochromocytoma, that is adrenal gland tumor, and mucosal neuromas of the lips, eyes, bumpy, lumpy appearance, marfanoid face, and megacolon. Here you can see Werner syndrome, adenoma of the pituitary, then thyroid tumors, and then insuloma, gut, gastrinomas, right? In MEN 2A, hyperparathyroidism is there, orthograms are involved, medullary thyroid cancer is present, and then pheochromocytoma, that is adrenal gland tumor. MEN type 2 is marfanoid face मिलेगा आपको, mucosal neuromas मिलेंगे, they may be on the tongue or other surfaces, medullary thyroid cancer is present, and then there are intestinal ganglionosis. Thank you very much. This was all about why is transplantation done? There was a question previously. Sorry, I did not answer that. Transplantation is done. Renal transplantation is done when a kidney is not working. When there is 70 to 90% loss of the functional status of the kidney, then renal transplantation is done. Or are you asking about the transplantation of the parathyroid gland? Because if we remove all the parathyroid glands, there will be no re-implantation, no calcium regulation in the body. So, and no parathyroid production. That is the reason why autotransplantation of the parathyroid gland is done. It is necessary to regulate the calcium levels of the body. That is the reason why transplantation is done. We do not remove all the 4 glands. Any more questions? I went very fast because you have already discussed with Dr. Zareen the medical treatment of the parathyroid, and we need to just talk about the parathyroidectomy, and it is a very small topic. Any more questions? Anyone?